Okay, thanks so much for having me today, guys. We're going to talk a little bit about the feeding therapist and breastfeeding in the NICU. So just a little bit up front, again, my name is Amber Valentine. I work for Baptist Health Lexington, an acute care facility in Lexington, Kentucky. I don't have any other financial or non-financial relationships to disclose. So what we're going to look at today throughout the webinar is being able to talk about concepts of recreational breastfeeding, or oftentimes I've heard it referred to as dry breastfeeding. We're going to list techniques for non-nutritive sucking, talk about at least 2 feeding cues or feeding readiness cues, and we're also going to talk about at least 2 ways to identify the feeding therapist's roles in supporting breastfeeding, especially in that NICU population. So when we look at breastfeeding, it should be considered the gold standard for feeding. In the past, we've kind of looked at the feeding therapist role as we support bottle feeding in the NICU, or as feeding therapists, we've supported bottle feeding. And you really saw that trending down with bottle feeding in the 80s and 90s because breastfeeding had trended down overall, especially in the United States. But now breastfeeding is trending up, or as somebody recently said, now that breastfeeding's big again. So I think now we really have to look at why we should be supporting this as feeding specialists, especially in that NICU population. So the American Academy of Pediatrics says breastfeeding and human milk are the normative standards for infant feeding and nutrition. And given the documented short and long-term medical and neurodevelopmental advantages of breastfeeding, infant nutrition should be considered a public health issue and not just a lifestyle choice. So what the AAP is talking about is that we should be looking at this as preventative medicine instead of just talking about, oh, you chose to bottle feed or, oh, you chose to breastfeed. We're really looking at this as how we can prophylactically help prevent diseases for not just baby but also for mom. When we look at the World Health Organization, they recommend that low birth weight infants, including those infants who are very low birth weight, should be fed mother's own milk. And we'll talk a little bit in a minute about why that's so important. If these infants cannot be fed mother's own milk, they should be fed human donor milk. They also report that low birth weight infants who are able to breastfeed should be put to the breast as soon as possible after birth when they are clinically stable and should be exclusively breastfed until 6 months of age. Low birth weight infants who need to be fed by an alternative oral feeding method should be fed by cup or spoon and should be fed based on the infant's hunger cues, except when the infant remains asleep beyond 3 hours of the last feeding. So that's all from the WHO. And I think one of the things that we look at in healthcare, especially if you work in a NICU or hospital facility, is the Joint Commission standard for breastfeeding is now 80%. Now, basically what that means is they want to see 80% of babies in the hospital setting at least attempting to breastfeed. However, I think if we look at our own facilities, most people aren't meeting that 80% marker. So the WHO and UNICEF came out with 3 strategies to help increase breastfeeding initiation and duration. They are promotion, protection, and support. So when we look at promotion, this focuses on the advantages of breastfeeding on a personal, community, state, or global level. So we kind of have to break it down in how we as individual therapists can help support this, this idea and concept. Protection focuses on governmental, manufacturer, and social responsibility to assure breastfeeding's ability to compete with commercial interest. This includes addressing improper marketing practices as described in the International Guide of Marketing of Breast Milk Substitutes. So, for example, if anybody's ever had a baby, they might send a Similac bag home with you with free formula or free formula marketing tools throughout that bag. So the example that the WHO gave for this would be, instead of sending a bag home from Similac or Enfamil, for example, sending a bag home with the hospital's logo on it and something that provided the family with things from the hospital. So the last piece of that triad that we look at is support. And this focuses on the interaction of helpers with family as well as program development and implementation. So as feeding therapists, we have to look at not only our responsibility for evaluating and treating infants in the facility while they're there, but we have to think about what's going to happen with these babies and their families once they get discharged. So it's very, very important for us to not just provide discharge education, but also to provide resources in the community. For example, I work in a very urban area, but most of my patients come from rural areas. So it's my responsibility to help find things in their area that can help support them if they want to continue with this process. So we look at things like lactation clinics and pre-counseling support, look at La Leche leagues in their area or other things that might help support these families after discharge from your facility, but also looking at the family unit and seeing how you can help provide education for not just the mom or the dad, whoever's caregiving, but their entire family support, including their pediatrician after discharge. So the other process that the WHO came out with to help promote this breastfeeding, this new idea of breastfeeding, was they came up with the Baby Friendly Hospital Initiative. And what the Baby Friendly Hospital Initiative is designed to do is help implement these 10 steps to successful breastfeeding. And if you look at other countries, for example, China has some upwards of like 5,000 baby-friendly hospitals, whereas in the United States we probably have like 500 or 600 baby-friendly hospitals. In the state of Kentucky, we have 2 of the university hospitals that are now considered baby-friendly hospitals. So when we look at the 10 steps for the Baby-Friendly Hospital Initiative, it seems like these are the things that we would already be doing. However, it's very, very rigorous to try to get some of these things implemented. The first example is have a written breastfeeding policy that is routinely communicated to all healthcare staff. This would directly affect therapists in that we would be providing this care and also helping educate our colleagues and peers, so PT, OT, speech, dietitians, nursing staff, patient care techs, anybody that's going to be working in the NICU or even on mother-baby, pediatric floors, and so forth. So providing that a policy that everybody is following. Number 2 is train all healthcare staff in skills necessary to implement these policies. So looking at how we can further develop this knowledge throughout. We can't just have lactation consultants or just speech pathologists working to help breastfeeding because there's only a few of us in each facility. So we really need all staff to be able to be trained in this so we can provide these patients and their families with a continuum of care. On the third one, we're going to inform all pregnant women about the benefits and management of breastfeeding. So when we look at this, we can also talk about education access to providing to OBs or pediatricians in the community. So looking at especially infants that we might see as feeding therapists in the NICU that might be an infant with Down syndrome, for example, or an infant with a cleft, providing these OBs with the services that are available in your area so that you can kind of get these families on board early and say, this is possible and there is support out there if breastfeeding is the goal. The fourth one is helping all mothers initiate breastfeeding within 1 hour of birth. Now, this one gets a little tricky, especially when we're looking at the population that most therapists are servicing, and these are patients that oftentimes are going to be having difficulty anyway. So the idea is at least getting these babies skin to skin as soon as possible, and that kind of, when we look at 4 or 5, goes hand in hand, showing mothers how to breastfeed and how to maintain lactation, even if they should be separated from their infant. Most often the babies that we service are in the NICU, or for example, a baby maybe that's on mother baby that's a late pretermer. Her mom is struggling to breastfeed. So we need to make sure that we're providing not only education on how to breastfeed, because even though it seems like it would be intuitive, it's oftentimes very, very difficult because these little babies are having some other comorbidities. And then we also need to look at how to help them keep building up that milk supply, because in those very, very early days, it's critical for these moms to start pumping to get their supply built up, especially if it's a baby who cannot get to breast frequently or who isn't very efficient. Number 6 is giving newborn infants no food or drink other than breast milk unless medically indicated. So this we have to be very careful with, and even though this is a very good policy, we also have to look at what medically indicated means. And most facilities have a policy on hypoglycemia, and this is what you would deem as medically necessary, especially in that very early stage. We're looking at babies that can get to breast as soon as possible, and even if mom is trying to nurse regularly, the baby is still maybe not getting enough, mom isn't producing enough milk at this point, we look at hypoglycemia rates. The American Academy of Pediatrics guidance as of 2011 was that there wasn't any current evidence that supported a specific concentration of glucose level in these newborns. So what they look at is a reasonable number, and they consider that reasonable number about 40. So what we have to do as feeding therapists, if we're in on these little guys, is to make sure that we're really staying on top of their labs and help support all staff members and all family members to say, okay, this baby's at 40 or getting close to 40 for their glucose level. How can we help support them and get that bumped back up? So number 7, practice rooming in, and this is allowing mothers and infants to remain together for 24 hours a day when possible. So the biggest thing is looking at your facility and how it's equipped. Newer facilities or facilities that have been specifically designed for the Baby-Friendly Hospital Initiative allows mom or dad or a caregiver of some sort to be in the room with that baby. And the longer that mom is in the room with that baby, the more contact time for breastfeeding that mom is going to be able to have. Number 8 is encouraging breastfeeding on demand. And when we talk about this, we're going to really be looking at that cue-based feeding model. I'll talk about that towards the end of the presentation. It's very, very important when we talk about successful breastfeeding to look at cue-based feeding. Number 9 is give no artificial nipples or pacifiers. This talks about bottles and so forth. However, when we look at the NICU population and we talk about pacifiers, it's very, very different for those little ones, because when we're doing gavage feeding or feeding through an NG tube or an OG tube of some sort, it's actually, the research says that it's very good for them to be doing pacifier use during this supplemental feeding, because it helps them associate food in their little bellies to positive sucking experiences. So it's a little different when we look at full-term breastfeeding babies versus babies in the NICU who might be getting some kind of gavage feeding. And the last one is fostering the establishment of breastfeeding support groups and referring moms to them after discharge from the hospital. And that's what I was just discussing previously about that support system, that we're not only providing support while our families are in the NICU, but helping support them after they leave as well. So the WHO also came out with a hierarchy of feeding, and I thought this was very interesting. The number 1 is mother's own breast milk, and this can be not just mom attaching baby and being able to directly breastfeed, but this can also include expressed breast milk. The second one is donated fresh preterm milk, and the reason why is preterm milk has a different composition than full-term infant milk, so it provides a good balance of nutrients that those preterm infants specifically need, helps prevent infection, and it's easier to digest. It's a different complexity or a different biochemistry than full-term milk. The third ideal situation would be donated fresh term milk, or that mature milk. So again, we still prevent infection. It's still more easily digested than a manufactured formula, but it might have slightly different composition than that preterm milk. The fourth option is pasteurized donated milk. When they look at usually a culmination of milk that's been donated to, for example, a milk bank that's all pasteurized together and combined, and it gives quite a variety of different components throughout. However, it's still a better option. Number 5 is preterm formula. So it's less easily digested than breast milk, but will have a different composition than the 6th one, which is ordinary formula. And the way the WHO describes it is that ordinary formula has the wrong balance of nutrients and no anti-infective properties. When we look at breast milk and the biochemistry of breast milk, each dose of breast milk that an infant gets is like building its antibodies up. It's like its own immunization every time it receives that breast milk. So kind of looking at this gives us a different perspective about what we're truly feeding these infants. So really, when you think about it as a therapist, it's a paradigm shift. If humans are designed for human milks, then that should be the standard goal for any setting. And as professionals, we have to think, are we looking at human milk and breastfeeding as the norm and bottle feeding as an adaptive strategy? And I think, like I said, when it trended down in the 80s and 90s, that bottle feeding was the norm, and this is how marketing tended to lead us to. We kind of thought that bottle feeding was the easier way, and now we're looking more at going back to the idea that breastfeeding is the norm and bottle feeding is a strategy. And most importantly, we should always be looking at evidence-based practice. And I think if anybody's practiced for any amount of time, what we look at is evidence-based practice isn't just the research, but it's the research, it's our clinical experience, and it's also the most important thing is the patient and family's values and expectations, especially in this preterm, this NICU population, is because we have so many things affecting what's happening to these little ones and their families at this time. So we really have to look at this triad of care and how, as a team, that we can approach this to have better continuity of care for these families. So I keep talking about the team approach. So who all is involved when we look at feeding in the NICU? So the biggest part of the NICU is collaboration. When we look at our nursing staff, they support feeding as a developmental skill. Nurses foster that dance of attachment. Oftentimes nurses are the ones that are consistently feeding the infants, even though it might change from shift to shift. The nurse is the one who's in there. They're sort of the mama bear of care. They encourage and promote kangaroo care. They can identify feeding cues and determine if baby is neurodevelopmentally ready for PO intake. They carry out the feeding plan as baby is appropriate, provide non-nutritive sucking opportunities. They collaborate with the entire team, and they educate parents. Again, nurses are sort of the captain of the team, so to speak, and they help with all this collaboration of care. We can also look at nursing assistants in the NICU. They can help watch for feeding cues and alert the feeding team. A nurse might have a baby who's feeding at the same time as another infant they're seeing. So if nursing and their patient care tech can work together, they can maybe watch for these feeding cues a little more closely. They can assure the baby is free from the baby's room is free from distractions and developmentally appropriate. And they can also work on this non-nutritive sucking skills during gavage feeding after the feeding therapist has seen the baby. Occupational therapists obviously have a huge role in the NICU. They can facilitate in things that baby is doing throughout their NICU stay, sleeping, feeding, interacting with parents, that social interaction that we're building at this young level. If they're using their eyes and hands to explore their environment, you think in a NICU environment oftentimes seems very sterile because these babies look at the same four walls all the time. So it can be the job of all therapists to develop ways that this baby can be engaged throughout their stay, looking at some more support and promoting feeding through neurobehavioral organization. And one of the most important things about pre-feeding readiness is that babies can stay organized. If they can't stay organized, then they can't feed appropriately. So really looking at how the therapist can work on these neurodevelopmental skills to help these babies become successful feeders. Looking at positioning, helping babies get to midline, and looking for those bonding with their parents and caregivers. When we look at physical therapy, they're in charge of that motor development and that core strength and stability. The rule of thumb is kind of stability before mobility. So if we don't have that early stability with these infants who oftentimes honestly are laying in a bed or are in maybe something like a mamaroo or so forth, because that's kind of the expectation for them at that time is just to maintain state organization. So really working with the physical therapist and trying to figure out what's the most stable position for these babies to feed in. Oftentimes the physical therapist is in making sure to educate everybody on not putting a lot of pressure on that baby's belly. These babies in the NICU are often very neurologically underdeveloped and their guts are underdeveloped. So really giving these infants the most successful opportunities to be good feeders and not promoting all that pressure on their belly to help maybe eliminate what they've eaten already. Limit time in baby equipment and aboard positioning in car seats. When you look at the way baby is positioned in a car seat, it oftentimes puts pressure on the belly, and if it's after a feeding, then this baby could be very, very sick, have lots of emesis after the feed. Dietitians. As a feeding therapist, the dietitian should be your closest friend. The American Dietetic Association said breastfeeding is an important public health strategy for improving infant and child morbidity and mortality and improving maternal morbidity and helping to control healthcare costs in 2009. So again, we're not looking at breastfeeding as just a lifestyle choice, like the WHO and the AAP were saying, but we're looking at it as prophylactic and preventative medicine. Breastfeeding is optimal for nutrition, so you're going to be working closely with the dietitian to see if this baby is breastfeeding, how much breast milk is the baby receiving, and if this baby is not gaining weight appropriately for the standards and protocols of that NICU, then also what are they supplementing mom's breast milk with to help with growth and nutrition. This little guideline here, this formula for nutrition, kind of gives you an idea that formula is not formula, and that was kind of eye-opening for me that all formulas are not the same across the board. One of the most easily digested formula is partially hydrolyzed, and it's 100% whey. And if you look at it, it's very, very creamy, and it's much easier to digest than something that's more whey or more casein, for example. So looking at what these babies are getting supplemented with. Also looking into ways to fortify breast milk with human milk fortifier instead of cow's milk fortifier, because then we're adding more cow's milk protein into mom's milk and therefore making it harder for babies to digest this. So when we look at the doctor, obviously they're guiding the total care of the infant. They're orchestrating consultations and providing that collaborative care model, and they're also collaborating with parents and families. The doctor's the head of the pyramid, so to speak, and they're listening to everybody's different perspectives and kind of helping orchestrate that all so that we're working as a cohesive team. So ASHA came out with this article called The Feeding Dream Team, and they said that the lactation and consultant and the speech pathologist were considered the feeding dream team, that together they brought overlapping and unique skills to the table when assessing and treating infant feeding difficulties, and awareness and respect for each other's roles, as well as forming a partnership, will not only improve the quality of care provided. So kind of looking at what the lactation consultant and the speech pathologist does bring to the table to see how they can promote the most positive breastfeeding experiences for these families to help make this successful. The lactation consultant assess and evaluate adequate milk supply. Again, promoting pumping is needed. If this is a mom who can't get baby to breast soon or often, we need mom pumping to build up her milk supply. They assess the infant latch. They're looking at some of the anatomy and physiology. Intervention for the lactation consultant is providing instructions and education on how to increase milk supply, positions for nursing, and help promoting that skin-to-skin or kangaroo care. And the speech pathologist assesses and evaluates pre-feeding readiness. Oftentimes in the NICU, the speech pathologist is the very first person to see an infant for feeding. So we're looking at those feeding readiness cues and skills that that baby's offering. We're looking at the oral and pharyngeal phase of the swallow. So we're doing a thorough oral mech exam. We're looking at latch when we're talking about babies breastfeeding, but also if baby's going back and forth from breast to bottle, we're comparing the way baby is latching to the breast and to the bottle. And we're also looking at how baby's able to transfer milk when they are on the breast. When we look at our NICU little ones, oftentimes they're very, very tiny and they don't have a lot of endurance. So their latch might not be as strong or as appropriate as their fully developing peers, and they might not have the endurance to transfer milk readily. When we look at pharyngeal swallows, we're looking at stress cues. I have a slide here in a few minutes that talks about different stress cues and if they're minor or major, and looking at needs for instrumental swallowing assessments. Like I'd mentioned, these infants in the NICU oftentimes have many comorbidities, and these can oftentimes affect their ability to swallow. So really looking at these cues and seeing when we need to step in and do further investigation. So for the intervention, we promote feeding readiness, positioning for nursing, looking at different tools such as nipple shields or supplemental feeders. We'll talk about that in a little bit, and providing education to parents and supporting staff. So why should speech pathologists care about breastfeeding? The American Speech and Hearing Association has long accepted the prevention of communication disorders as one of the profession's primary responsibilities. When we look at breastfeeding and all the benefits that it lowers the risk of GI infection and improves the motility and the formation of the gut flora, helping develop these more positive developmental skills. It improves their respiratory skills. It reduces the risk of otitis media. It increases IQ. So all of these can impact the child's ability to communicate as it continues to grow and develop. That breastfeeding should be considered developmentally supportive care. We should support the infant's physiological stability, self-regulation, behavioral organization, and developmental progression. When you look at all the research out there, babies are more stable at the breast. Again, mentioning that these infants oftentimes have more than one thing happening with them. If we can keep them stable for feeding, we will have a better success at them being good feeders. And ASHA practice recommendations are that clinicians providing pediatric dysphagia services should have knowledge and skills to assess and treat breastfeeding as well as bottle feeding. And this has been as recent as 2014. They had an ad hoc committee for the speech pathologist role in the NICU, and it spoke about how we should always be assessing breast and bottle now. So when we look at neurodevelopment, why is cue-based feeding important? So feeding is the most complex task that we ask infants to do. And when we look at this population in the NICU with all these things that we have going on for them, and then we expect them to be good feeders on top of it, we have to think about what we're asking our patients to do. Feeding is a time to continue to develop positive motor and sensory neural pathways. Everybody that helps these infants in the NICU are creating the neural pathways that are going to help this child grow and develop. So if this infant is experiencing negative experiences throughout their NICU stay, that kind of lays a pavestone for negative experiences in feeding later on in life. If feeding is a critical element of patient care, it's a time for family and infant to build relationships. Positive feeding experiences during infancy lead to positive relationships with food and meal times for children and families throughout the lifetime. Oftentimes, these babies that were in the NICU, especially babies who had negative feeding experiences, turn out to be our picky eaters. So they aren't just babies that someone might see in the NICU for a couple of weeks or a couple of months, but these may turn into children who are seen by therapists in early intervention or in outpatient facilities, or oftentimes even when they go to school. So we're looking at helping create good feeders, not just a good feeding, trying to look at the broad picture of things. Professionals should foster the parent-infant relationship during feeding by supporting and guiding the parents and infants to have positive feeding experiences, teaching families why that these are such important skills for them to learn, to help facilitate that baby-parent dance of attachment, or that social interaction between parents and their infants. Empowering parents to understand their baby's behaviors, reading their baby's cues. Babies are good communicators, so we have to help these families to read what their babies are trying to tell them and trust in that establishment of that bond. Shaker said in 2013 that a lack in continuity of the feeding approach and communication can adversely affect the baby's overall feeding experiences, leading to decreased PO intake and longer hospital stay. So, for example, if there's a breakdown in the continuity of care throughout the NICU, maybe for speech pathologist might recommend one thing, and the physician might recommend another, and a nursing staff might recommend something else, and we don't have good cohesive care that we're offering our parents, it can often cause a breakdown and make that baby end up being in the NICU for longer than they need to be. So the take-home message on that is that feeding should never be considered a care task. This isn't a diaper change or a temp check or any of those things, but feeding should be considered a social interaction. If we look as society, what we do for holidays and birthdays and meetings with colleagues or get-togethers with friends, what we're looking for is social interactions. We go eat. So if we help create positive experiences for these babies in the NICU, then we can help create positive social interactions with feeding as they continue to grow and develop. So as I'd mentioned, here's a little bit about stress cues. When we look at the column on the right, the minor stress cues, if baby's irritable or frantic, disorganized or difficulty latching, if baby's having respiratory fatigue, any tachypnea or increased work of breathing, if baby's demonstrating nasal flaring or blanching, they're trying to really open up their nasal passages to get extra oxygen in, they're struggling. Something's going on with the breakdown in that system. If they're gulping, if they demonstrate minimal drooling or minimal anterior loss. So these are minor stress cues, but these are cues that we need to be reading throughout the feeding, whether it's a nurse, a feeding therapist, a parent, because we need to be looking at why that baby is giving us these stress cues and what's happening with the feeding. When we look at the left side column, and I put them in red for a reason, if we have any of these major stress cues, that baby is extremely communicative in what they're trying to tell us that this is not working for them. If baby is coughing and choking, if baby has any kind of change in color, bradycardia event, breast holding or apnea throughout the feed, if they're demonstrating any kind of stridor, a decrease in oxygen saturation, multiple swallows, or moderate drooling. And it used to be kind of a theory that if babies were losing a little bit, that was okay because all babies lose a little bit of liquid when they're feeding. But if you look at a baby who has a nice latch and their lips are sealed well around the breast or bottle, they're not going to have any anterior loss. So if baby is losing lots and lots of liquid out of its mouth, it might be that the baby's getting too much bolus. It's not able to breathe and support that bolus, so it's pushing it out the front because they have to have compensatory strategies. They are adapt to help themselves breathe better. So this is how the baby's trying to tell us, I can't do this. This is too hard for me. We have to remember that clocks have batteries and babies have brains. So we're going to talk about cue-based feeding and talk about how important it is to read our babies and how they're telling us what's happening. So as a feeder, we don't try to take over and push things on these little ones that they aren't necessarily ready for. So we look at breastfeeding in general, especially for the preemie population. The bioavailability of the nutrients in human milk is higher than other foods. Like I mentioned earlier, preterm milk is appropriate for preterm babies. It has a different composition for the first 30 days after delivery. It's higher in protein, fat, electrolytes compared to that more mature milk. And mother's breasts make baby-specific milk. So, for example, if a mom is nursing maybe a toddler or an older baby and then has had a preterm baby, the mom's milk is going to be made very specifically for that preterm baby. Preterm milk also improves neurodevelopmental outcomes, Infants fed breast milk have faster brainstem maturation compared with infants fed preemie formulas, especially for those born between 28 and 32 weeks. It improves eye and brain development in preterm infants. Again, this is very specifically made for these infants and their ability to try to, quote, catch up as they're making their way towards what they would be if they were full term. It has a large amount of respiratory and GI benefits. It reduces the risk of chronic lung disease, RSV, pneumonia. In very low birth weight infants are less likely to exhibit oxygen desaturation to less than 90% during breastfeeding. If you look at a baby on the breast and then you compare that same baby on a bottle, oftentimes you're going to see that the baby on the breast will keep their saturations well into the 90s, but if you put that baby on a bottle, they might drop into the 80s or sometimes even lower. And it's because physiologically they are able to manage the breast better than the bottle. They can control the flow, and the infant has the entire control over the feeding, whereas on the bottle, the adult is the feeder, and the infant has lost that ability to control that situation. There are hospitals that have policies to allow breastfeeding in high-risk populations who have been known to be aspirators. If you look at UNC Children's Hospital, they have been doing breastfeeding for infants who are aspirating because it's considered a benign, or if it's coming directly from the breast, it's considered much more manageable, and it has all those healing properties. From the GI perspective, it reduces the risk of necrotizing enterocolitis and other infections. These babies' guts are underdeveloped, and if we introduce foreign things to the baby, for example, artificial formulas, we're changing the bacteria of those babies' guts. If we stick with mom's breast milk, or at least preterm breast milk, then we're at least trying to help induce that good gut flora and develop that GI system to be appropriate to be able to accept foods as they continue to grow and develop. It reduces the risk of diarrhea. Diarrhea is the #1 cause of infant mortality, so if we introduce breastfeeding as soon as possible, it reduces the risk of diarrhea. Low iron in the stomach with breast milk, so the organisms can't grow and multiply. Absence of the exposure to contaminants, for example, bottles, nipples, water, and formula ingredients, because anytime you introduce an outside source, you run the risk of contamination. Even in the most sterile environment that we can possibly provide with good hand hygiene and sterile equipment, we're always going to run the risk of introducing contaminants. When baby is breastfeeding on mom, that drastically reduces the risk of those contaminants. So we talked about baby's benefits, but we also have to think about mom's benefits. And I know sometimes what happens is when we're working with babies in the NICU, we often forget that although baby is our patient, really so is mom and family, and we really have to look at that dynamic, that relationship between them to kind of help provide that support. And we're trying to encourage mom to breastfeed because it's good for baby, but sometimes what mom needs is to see overall the picture is that it can provide such a good, healthy relationship for both of them. It can provide her with benefits to improve bone density, reduce hip fractures, reduce postpartum depression. And I think that's very, very important when we look at families with infants in the NICU, because one, they've already had one goal that's not been established. They might have had a specific birth plan, or they might have had specific expectations for this infant, and they've sort of already had those goals shattered because now they have a baby in the NICU, which is not anyone's plan. So these moms are at high risk for postpartum depression because they're separated from their infants and they're going through a grieving process. By encouraging skin-to-skin and breastfeeding, you can help reduce the risk of postpartum depression. It enhances the self-esteem in the maternal role. You're telling these moms, look, this is what you can do for your baby, and you're the only one that can do this for your baby. So it gives them sort of this new role of self-esteem. Like I said, we're thinking about moms who are oftentimes grieving because things have happened in ways that they didn't think. So kind of encouraging mom that this is what you can do for them. It encourages that strong bonding with the infant, especially if it's a mom who can't be in the NICU 24 hours a day. When they're there, if they're providing this skin-to-skin and these breastfeeding opportunities, it gives them a stronger bond. So we know it's good for baby. We know it's good for mom. Why is it so hard? Unrealistic expectations, lack of timely interventions and support. The Healthy Children's Initiative reported that the fastest drop-off in breastfeeding is in the first 10 days after discharge from the hospital. Now remember, this is not after the baby was born, but discharged from the hospital. When mom and family is in the NICU, they have 24-hour support. Now they are discharged from the NICU and they are expected to take this infant home who's kind of gotten off to a rough start and they don't have any support. Do we have breastfeeding drops because of misinformation about why mom's stopping breastfeeding? One of the number one things that you hear for moms who stop breastfeeding is because they're not making enough milk. And that's oftentimes very, very untrue, even in the NICU population. Now, that being said, pumping and providing breast milk for 6 to 12 months via pump is very, very difficult, especially if they're not getting any of that direct skin-to-skin or direct breastfeeding opportunities. There's also the looking at a mom who maybe, for example, had HELLP syndrome, or a mom who just had extremely high blood pressure and they were maybe on magnesium or something like that. So mom is in the hospital for longer than expected and couldn't get to the baby as soon as possible. So now we've got a breakdown in this process for breastfeeding. So as care providers, we need to be able to provide this mom with as much support as possible. Like I said, getting her pumping, getting her to baby as much as she possibly can and is physiologically and stably able to do, and allowing mom as much opportunity to be with baby in the NICU as possible. So this diagram kind of gives an idea of how milk is made in moms. It's a very sensory supported system. So mom's body is biologically made to respond to her baby. So the concept of recreational breastfeeding, basically, or dry breastfeeding, is what it is. Instead of supporting non-nutritive sucking just from the perspective of a pacifier, we're looking at recreational breastfeeding to support that idea or that concept of non-nutritive sucking. So non-nutritive sucking provides experiences to promote eventual nutritive sucking and breastfeeding skills. It's optimal after 15 to 20 minutes of kangaroo care, and it helps baby with that physiological organization, that state organization, making sure baby's calm, their respiratory rate is controlled, that baby doesn't feel out of sorts. Mom pumps breast until empty or as empty as possible. The breast never truly empty, but mom pumps breast until there's no more milk flowing. Baby's dressed in a diaper and a hat, or at least where they can maintain their temperature, and baby is placed nose to nipple for an appropriate latch as much as possible, especially in the NICU population. So we want babies not just skin to skin with mom like in kangaroo care, we want them actually trying to latch on or at least try to provide some stimulation to mom, giving baby that oral experience next to the breast to give them an idea of what that feels like. Nerve fibers of touch and smell lead directly to the amygdala, which provides sensory information for emotional memory and fear conditioning. This is one of the reasons why babies are more physiologically stable when they're at the breast than at the bottle. Because in this situation, mom's chest is home base. Mom smells good. She sounds good. This is what baby has been living with for X amount of weeks and months. So this is where baby feels most comfortable. Mom's breast can actually help baby regulate body temperature. So baby can maintain their own body temperature much more stably when they're next to mom than they can, for example, just in the isolette. And then again, even though baby's not actually nursing, getting any nutritive sucking going on, this just gives them those early feeding skills. So for baby, we get that homeostasis, that physiologic stability, helps develop sucking latch. It allows baby to bring hands to midline. We want baby's hands at midline anyway for feeding, so babies bring hands to midline and they can massage mom's breast. That gives mom stimulation to make more milk. We're talking about mom who isn't next to baby as much as she needs to make good milk production, then baby's hands coming to breast can help provide mom with that stimulation that she needs to produce more milk for her baby. It improves that cardiorespiratory stability. Exposure to the infant's NICU environmental pathogens stimulate the mother to produce antigens particular to her baby's needs. So that's a pretty cool phenomenon. Just mom being in the environment that her baby's living in, her body is building up antibodies to help her baby reduce the risk of infection to exposure in that NICU setting. So for mom's bonding with baby, she's using that skin-to-skin. The sucking increases her prolactin levels to help increase her milk supply, and it's helping her reduce some of that stress. When she's next to her baby, she feels better. So as feeding therapists, what's our role? To encourage recreational breastfeeding. If our goal is for mom and baby to be successful at the breast, we have to start out with these early feeding skills. We need to make sure that when baby is cueing to feed, when they're giving those early feeding cues, to get baby to breast as easily as possible. We can do this during gavage times, again, like a pacifier. If we're putting baby to breast and baby's getting belly full, they can associate those positive experiences with latching to mom and getting their belly full. We want to make sure that we're ensuring and promoting adequate latch, educating mother to ensure that with each attempt that she's latching appropriately or at least helping baby latch appropriately, to encourage proper latch without the use of a nipple shield if possible. There's lots and lots of research out there about nipple shields and pro and con and so forth, but what we're trying to do is just get baby skin to skin as much as possible during this recreational breastfeeding stage. And educate and encourage families to read those feeding cues, help them position for feeding, help them monitor their baby's state and that homeostasis throughout the feed, and giving them benefits of breastfeeding, how to breastfeed the baby when the baby is ready. After we've gone beyond that recreational breastfeeding stage, when baby's showing these feeding readiness cues, we're going to be the ones that are getting in there and helping this baby feed and encouraging mom to help maintain that milk supply. So we talked about non-nutritive sucking, but the important take-home message is just because a baby gives you the ability to non-nutritively suck, whether it be via the pacifier or that they're doing these great recreational breastfeeding, that doesn't always mean that they're necessarily ready for nutritive feeding. So we kind of have to disassociate that a little bit. And while it's a good developmental milestone, a good stepping stone that we want to have non-nutritive sucking before we nutritively feed, it doesn't always mean that they go hand in hand. So I'll just caution us to be careful as feeding therapists to think that just because we're sucking on the pacifier or trying to latch to mom that they're necessarily ready, because it's the moment that fluid comes out, that's a whole other physiological component that we're asking that infant to do. So now we're going to look at breastfeeding, the idea of that suck, swallow, breathe concept. Are we ready? So we assess breastfeeding readiness similar to bottle feeding, however, keeping in mind that infants may be able to attempt breastfeeding slightly earlier than bottle feeding due to state regulation with that skin-to-skin contact. Like I said, babies feel more stable when they're at the breast. They can self-regulate a little more easily, so they might be able to feed slightly earlier than they would if we were only looking at bottle feeding. So what we're looking for is stability with handling. If we can't get baby out of an isolette or out of their crib without them being physiologically unstable, without them being able to have any kind of state organization, then most likely that baby may not be ready for this. The baby's showing interest in oral feeding. They're smacking their lips. They're bringing their hands to their mouth. They're giving you sucking without anything in their mouth. Those might be signs. Baby's saying, hey, I'm ready. Let's try this at least. And it should be all infant-led. So the progression would go from skin to skin to actual exposure to the breast or that recreational breastfeeding. Baby's getting some licking, latching attempts, and then to eventual latching and sucking. So this is kind of a nice schematic to give us an idea about early feeding cues, mid-feeding cues, and late feeding cues. And I think oftentimes that we as feeders think that if a baby's crying, that means that that's when they're hungry. But really the truth behind that is if a baby's crying, they're past that point where they're hungry. Now we've kind of missed the boat. So those early feeding cues, like I mentioned, is the baby's starting to stir around if they're sleeping. They're giving you nice mouth opening postures. They might be turning head from side to side, or they start rooting, maybe on their arm or on the caregiver's hand if their hand is near their mouth. Those kind of mid-level cues, baby's getting hungry, they're stretching, increased physical movement, they've got their hands to their mouths, they're showing you they're ready for that activity. And like I said, these late cues, that if baby's crying, then what we need to do is instead of worry about feeding in that moment is that we need to get baby calmed down back to that homeostasis so that we can try this whole process again. They might need cuddling with mom, getting that skin-to-skin going, just getting baby kind of back together before we try. So there was often this idea of nipple confusion, and really what it is it's not nipple confusion when baby's going back and forth between the breast and the bottle. It's actually flow confusion. So the biggest physiological difference in the breast and the bottle is the flow rate. Baby-driven versus passive-driven flow. So when baby's on the breast, baby has control over this. When baby's on the bottle, that bottle will continually flow regardless because it's a hole and the feeder has control over it. So the baby has the less control of the feeding. Breastfeeding allows ability to stop and modulate flow with movements of the gum and tongue. Babies get very, very good at adapting. So they figure out mom's breast flow rate the more they're exposed to breastfeeding, and they can learn to control that flow on the breast. The biggest or I guess the largest amount of flow that baby is going to experience is that milk ejection reflex in the beginning, or the letdown phase. So babies in the beginning of breastfeeding often suck and suck and suck and don't get any kind of reinforcement, and then mom will experience a letdown, and that's when that large amount of flow happens. And then as the feeding progresses, the flow slows, and then the milk gets thicker, and the baby has more ability to control at that point. So when we look at successful feeding, we're looking at the difference in experience versus volume-driven feeding. So when an infant is learning to oral feed, the experience is more important than the volume. This is also when we're looking at the difference between cue-based feeding and scheduled feeding, is because we are also looking at, again, being the feeder and being in control over it. We want the most important concept to come from every feeding experience is the baby is having positive experiences and that they're willing to go back to PO feeding, whether it be the breast or the bottle, for the next feed. So if we're constantly overloading these babies and they're not having a good experience, then oftentimes at the next feed they may shut down and they may not want to do that at that care time or that feeding situation. Feeding is a developmental skill, so we always have to remember that we're teaching things. Again, not a care time, it's not a diaper change or a temp check, that we're teaching a skill to these babies that's going to go with them across their lifespan. The goal is to have infants become successful feeders, not just successful feedings for each individual time. And even in the NICU, I know that we're worried about weight gain and nutrition and development because that's the way that we get these babies home. But instead of looking at individual feed, oh, that baby took 15 mLs, or oh, that baby didn't take their whole feed, we really need to look at babies' nutritional gain over 24 hours or even 36 or 72 hours, just looking at a broad spectrum instead of looking at each individual feed to see if that baby's truly being successful with what their PO intake is. So the concept is that slow and steady wins the race. This isn't a sprint. It is definitely a marathon for these little ones. So cue-based feeding, it's a co-regulated approach. It is a partnership between the infant and caregiver. So we are not in control as feeders. We need to allow the infant to be in control. The caregiver understands and uses the infant's communication to guide the feed, looking at physiologic and behavioral communication. Like I said, these babies are communicating to us. We just have to make sure that they're listening. During the feed, we need to observe the infant for movements or any of those signs of distress from that slide, especially the ones that were on the left, those major stress cues, and continuously modifying the feeding approach in accordance with the infant's communication. Even if we're looking at breastfeeding, we need to be watching these babies to see what they're telling us. If baby's coming on and off the breast, if they're having trouble latching, if they're uncomfortable, maybe baby's got a bellyache and they're telling us they're not ready to feed during that time. Really reading that baby's cues to tell us what's going on. A lack in continuity of feeding approach and communication can adversely affect the baby's overall feeding experiences. I keep saying this over and over because it's very important for us to realize how we treat these infants can affect their ability to not just get discharged from the NICU, but their ability to be successful feeders. So the next couple of slides just look at some research that's been developed about the impact of cue-based feeding, transitioning from volume-driven feeds to infant-driven feeds. And these studies look at different cohorts of infants based on postmenstrual age. The experimental group in this study received bottle feeding based on physiological and behavioral responses. The control group received standard care, so volume-driven feed. And the results in this study were that the experimental group achieved full PO nutrition sooner, gained more weight, and were discharged from the facility more quickly using the cue-based feeding approach. In 2012, McCain did a study where the infants born at less than 24 weeks with chronic lung diseases. In this study, the experimental groups were offered bottle feeding based on cardiorespiratory and behavioral responses. The results were very similar. The experimental group achieved full PO 5 to 6 days sooner than the control group. So again, we're looking at discharging sooner from the hospital, saving dollars and cents, helping out the insurance company, because that's oftentimes what's driving our neonatologists to push these babies out the door sooner than they may be ready with this idea of volume-driven feeding. But if we look at these research studies, what they're showing is that if we let the baby lead, then they actually can get out of the facility sooner. And the other one in 2012 showed infants less than 32 weeks provided co-regulatory approach to feeding, more stable oxygen saturation, less heart rate fluctuation and decline, and improved swallowing with less excessive breathing efforts. Again, babies look more stable on this is just a nice visual for us as we're talking about this idea of volume-driven feed. This is day 1, 3, 1 week, and 1 month of an infant's stomach size. Now, these are full-term, typically developing newborns. So when we think about our babies in the NICU, oftentimes this isn't even going to be the standard that we can go by. So on day 1, if baby's stomach is the size of a cherry, and the idea is only to get approximately 5 to 7 mLs, that's that first stage of milk development, that colostrum that moms get. Very thick, copious, fat, and sugary, perfect first milk for these babies, and 5 to 7 mLs is not very much. So the idea isn't that they need to get tons and tons of volume. Their bellies don't hold tons and tons of volume. So even by day 3, the size of a walnut is still only 22 to 27 mLs. And like I said, this is full-term infants. So we're looking at a month's gestational age for a full-term infant. 80 to 150, you're talking about 3 to 4 ounces, give or take a little more, 3 to 4.5 ounces. Some of these infants in the NICU, that's what we're looking at from a volume-driven approach, is trying to get these infants to take 2 and 3 ounces when they're very, very tiny in the first place and their bellies just can't hold all this volume. We're sort of setting them up for failure. One tool that we can use when we're looking at the NICU for helping moms, especially moms who are maybe having low supply, maybe they were away from their baby a little longer than they hoped, they didn't get that first skin-to-skin contact as early as they would like, we look at a supplemental nursing system. This is one of the things that I've kind of heard mixed reviews from different practitioners. One IBCLC that I spoke with said that she uses it for families that she feels like can handle it, that they can understand the device, they can manage and manipulate the device. But when we look at the NICU population, if we use this as a tool, and maybe not that this is going to be the baby's only feeding system for long term, but it's just a device that allows the baby to receive extra milk during time at the breast. So essentially it's the size of a small, for example, a 5 or 6 French tubing attached to some sort of system or a bottle, empty bottle or an empty syringe that milk goes in. It's attached to mom. And then while baby is attempting to suck, milk is coming out. So baby's getting reinforcement that while they are at the breast, they get fed. Provides positive reinforcement for baby to continue to work for something, and it stimulates mom. So if we're only feeding baby with a bottle and mom's trying to pump, mom is never getting that skin-to-skin, that stimulation to make more milk. But if we put baby to breast and we're still getting baby some supplemental feeding while they are nursing on mom, this can help increase mom's milk supply. It can help their milk come in faster. This can also be used for babies that we might see in the NICU with a weak suck, babies transitioning from bottle to breast, maybe babies who have a cleft, who have some neuromuscular difficulties, who have a multitude of things that are causing them to have difficulty breastfeeding. If we try the supplemental nursing system to at least give them that positive reinforcement, this oftentimes equals more successful breastfeeding. So when we look at bottles to support breastfeeding, we have to be very, very conscious that there is no bottle that's exactly like the breast. We have to look at very specifically types of nipples. A bottle is not a bottle is not a bottle, and that's why there's a huge manufacturing industry of bottles at the market. You can walk down any aisle at a store that has baby equipment, and you can see the multitude of bottles that are out there. As lactation specialists and feeding therapists, we need to be very, very careful about orthodontic nipples because they oftentimes encourage a shallow latch. So while we look at these nipples and they seem cuter, they might be easier for the baby, if we're encouraging a shallow latch for an infant who is trying to go to the breast, we do not want baby to be latching shallowly on mom. That can cause damage and be very, very painful for the mom. And we also need to look at nipples with abrupt changes from the nipple to the base. So we want a smooth transition from the tip of the nipple to the base of the nipple to make it easier for baby to get a nice wide open mouth across the bottle nipple, a nice open flange of the lips, so we can encourage bottle feeding to be as similar to breastfeeding as possible if this baby is going to have success going back and forth. Make bottle feeding more like breastfeeding. So not only are we looking at the equipment that baby's using, but we're also looking at how we're going to get them back and forth by the feed. So we need to mimic breastfeeding by letting baby pause and rest periodically. We need to allow baby to have a burst on the bottle. So, for example, mimicking that letdown. Like I mentioned, babies might suck and suck and suck with no reinforcement, and then mom has a letdown, and that's when they get their first taste of PO. so kind of mimicking bottle feeding as much as possible, and then allowing burst cycles throughout the feed. So this will help baby control the feeding as much as possible. It might be that we have to tip the bottle up to the roof of the mouth to let baby take a break, so there's no liquids dripping out, but you can still leave the bottle in the mouth. You just need to make sure you tip it up so baby gets a chance to rest and stabilize, especially if they're getting overwhelmed. This was a study that was done in 2015, and it looked at commercial bottles that were on the market. They hooked them up to breast pumps, and over a course of time determined which bottles flowed the fastest. And this just kind of went through all the ones that at that time they thought was used most readily in a hospital situation. And I just thought this article was interesting because it kind of shows us on here, it gives like the Similac slow flow or the Enfamil slow flow. And what happens is that down into the article, there's another chart that actually shows if you take, for example, the Similac slow flow disposable nipple that oftentimes we use in the NICU or Enfamil, whatever the hospital uses, is that when they looked at 10 different disposable slow flow nipples, all 10 of them had a variable rate. And it's because the integrity of the nipple is not held to the same standard as, for example, a bottle that you may have to go purchase at the store. They're meant to last because they're more durable and are supposed to be used over time. Whereas if we use these disposable nipples and expect baby to have some kind of regulation, all of these are very, very different. So kind of looking at this across the board and looking at how they flow, I thought it was interesting that the Dr. Brown's level 1 was very similar to the Similac slow flow. So how slow is the Similac slow flow? If we're looking at the Dr. Brown's level 1 that's around 0 to 1 month, it's really not as slow as we think it is as far as considering it a slow flow bottle. One of the tricks that we can use for mimicking bottle and breastfeeding is putting babies in this elevated sideline position. So it helps increase oxygen saturation. Babies have less heart rate variability. Their respiratory rate is closer to baseline. The easiest way to explain it is that the caregiver or feeder holds baby like they would hold baby in cross cradle for breastfeeding, and then move them out to the side for elevated side lying. Left side down allows for improved stomach emptying, helps these babies who already have some underdeveloped guts, might have some reflux going on. This can help this baby with the feed to maybe help them not bring as much up. So when we look at overall with breastfeeding, there's lots and lots of things that can affect mom's ability to breastfeed, especially in the NICU population. Again, one of the biggest factors is that oftentimes mom may be in the hospital as well. We also look at infant and what else is going on with infant. Is this an infant that was just preterm because maybe mom had high blood pressure, or is this infant have other things going on such as a cleft, such as Down syndrome, a heart problem, were they IUGR, so it was a baby who was little anyway, maybe wasn't getting enough nutrition throughout the pregnancy because of one reason or the other. So what other factors is impacting this baby? Is it an infant of a diabetic mom? We have to look very, very closely with the infant of a diabetic mom because these are very large babies, large for gestational age. They're very, very floppy in tone. And these babies oftentimes have a hard time regulating, especially in the beginning, because they're still trying to clean out their own systems. So we need to look very closely at those babies' labs to see why these babies are maybe sleeping all the time, so they're not awake enough to breastfeed like they need to. Really encouraging mom to pump as much as possible if she's away from her baby and is not able to provide that good skin-to-skin contact. And looking at other ways that we can support that mom and that baby when it's time to go to breast, and how we can promote the most successful feeding opportunities possible to help these moms succeed. I think oftentimes moms come in with the idea that they were going to breastfeed or they were not going to breastfeed. So as feeding therapists and providers of care in this NICU environment, it is our goal to educate on the importance of providing that great source of first food for these infants and helping them see why it's important and how we can support them to make that as successful as possible. So we just look at the areas for the mom. Emotional support. Like I said, these moms are grieving. These families are going through a lot. They're away from their baby. They're having to spend time in the NICU. They might be having to spend time away from other children in the house. They might be 3 hours away from the NICU, and it's just hard for them to get there. Or what other things are going on in these families' lives that are affecting their ability to make this as successful as possible. Providing physical support for mom, whether it be helping them with pumping, helping them with latch, helping provide skin-to-skin opportunities. It might be that we come to every feed as much as possible to help mom latch that baby every time because she just hasn't felt comfortable with latching that baby yet. Monitoring mom through the milk production process. We have to make sure that mom's hitting the stages like she needs to, going through that colostrum phase, to the transition milk phase, to the full mature milk phase. Because if mom isn't building enough milk, then she's never going to be able to feed her baby, whether via the breast or providing the baby with express breast milk. Looking at breastfeeding assessments, like I mentioned earlier, it is certainly in the scope of practice for speech pathologists to provide breastfeeding assessments. We're looking at mom and baby as a feeding dyad in that case, and I think often as speech pathologists that's very different for us. We're used to looking at just baby. So now we're looking at two people in this cohabitation of feeding. And then looking at appropriate referrals. If the speech pathologist is the first person to see the baby, who are we going to refer to? If it's the occupational therapist, who are they going to refer to? If it's PT, if it's nursing staff, looking at working together as a team to providing that cohesive care so we can make this as successful as possible. Looking at family support, maybe not just dad, but grandma, aunts, uncles, siblings, whoever is going to be supporting this mom and baby in this attempt to make breastfeeding successful as possible, and how we can provide support for them as well, making them feel like they're an integral part of this team. And also looking together collaboratively as a team to support each other. Because if we look at the NICU care team and we're constantly picking apart each other or not in agreement, it makes it very, very difficult for our families to see how much care that they're actually receiving. And we certainly as caregivers don't want to be providing any negative experiences for these families while they're going through this process. And then once again providing that community support for after these families get discharged from the NICU to allow them to continue on with this successful breastfeeding.